Good evening, everybody. And on behalf of Nata, I'm welcoming all the eminent people here. So for today's seminar, COVID-19 and its vaccination. So first, I'm going to welcome Dr. Premanna. So everybody knows here in the US and all over the world, in Telugu people and other people also, Dr. Premanna is founder and chairman of Prime Healthcare Services and Nata chairman emeritus, and Padma Bhushan Dr. Nageshwar Reddy Garu is the chairman of Asian Institute of Gastroenterology and very eminent person and got a lot of awards. Everybody knows him. And Dr. Astrazeneca Reddy Garu, gastroenterologist and Nata Advisory Council member, and Dr. Mohan Malma Garu, so internal medicine and geriatrics, and Nata Advisory Council chairman, and Dr. Sudhakar Jonalgad Garu, RP president and gastroenterologist, and he recently got Pravasa Bharatiya Samman Award, so one among 30 people in the world. So very great achievement. And also Dr. Talwar Garu is an eminent pulmonologist and critical care doctor. And Dr. Vishnu Chundi Garu, he is an infectious diseases and chairman of COVID-19 task force for CMS. And Dr. Praveen Sampath, gastroenterologist and Apna Foundation president. And our people, Nata secretary, and Ram Reddy Garu, and Nata past secretary, and present board of director, Girish Ram Reddy Garu, we are on behalf of Nata, we are welcoming here. And also, right now, I'm going to request Dr. Astrazeneca Reddy Garu to take over and continue the proceedings. Thank you.
Thank you, Raghava. Thank you very much. Welcome, all the attendees. So COVID-19 is a huge problem. I don't have to dwell on that. You all know that. In 1980, Winter Olympics in Lake Placid, New York, the American team consisting of amateur college students beat heavily favored professional Russian team in ice hockey. That was called Miracle on Ice. Now, launching the vaccine in a 10-month window is another miracle on ice. The vaccine is the light at the end of the tunnel. We are going to hear the safety and efficacy of the vaccines from real experts. So now I'm going to introduce our, the meeting is going to be inaugurated by a distinguished member. So I'm going to say a few words about our distinguished guest who is going to launch this meeting. So now the opening remarks by our friend who is a physician, an entrepreneur, a philanthropist, and a visionary. He was named one of the 50 most influential physician executives in the healthcare 9 times in a row, or at least 9 times, and frequently listed as one of the 100 physician leaders to know. He is current chairman of the Federation of American Hospitals. His company, Prime Healthcare Services that was launched in 2001 and owns 45 hospitals and provided more than 9 billion in charity and uncompensated care since 2010. I didn't say his name, but I'm sure you all know his name. So he's also a founder of Dr. Prem Reddy Family Foundation, which he has donated millions of dollars for various philanthropic activities, including launching a medical school in California. Without any further delay, let me introduce a great friend and philanthropist, Dr. Prem Reddy. Prem.
Thank you. Thank you, Astrazeneca Reddy, and thank you, Raghav Reddy, and thanks for all the Nata folks that have organized this webinar. and it's wonderful. This is actually second time Nata is organizing this event. We're living in very difficult times. We may call them crazy times. It's all over the world with an invisible enemy, the virus. So we're all trying to fight something that's invisible, that is very pervasive, and also causing a lot of sickness and death all over the world. Taking from the American perspective, because that's where I've been living for past 40 years, there have been 20 million Americans that were affected by this virus, out of which to date, around 370,000 Americans died. Unfortunately, 40% of them are about 65 years old. And also, it has been low socioeconomic communities, African Americans, Latino Americans. Here, Latino Americans mean came from Latin countries like South America mainly, have been unusually affected compared to white populations because of so many socioeconomic reasons. See, like Dr. Astrazeneca already mentioned, I own and manage around 45 hospitals. Looking at my own statistics, we have so far treated 19,000 COVID patients in the hospitals. And we tested and discharged 14,000 COVID patients from the emergency departments. We have performed 92,700 COVID tests. We have so far administered 30,000 COVID vaccinations, 20,000 vaccinations from Pfizer, and 10,000 from Moderna, because Moderna vaccinations came a little later. And of course, we're doing it every day, including today. Okay, so of the patients that we have treated so far, of the 18,000, 3,890 patients died. That means it's a 21% mortality in our hospitals. The statistics vary from area to area and region to region, because certain regions were badly affected. Originally started in East Coast, New York, New Jersey, and Midwest in Michigan. And now today, there is a resurgence in most of the East Coast, but predominantly in certain areas like South Texas, where our hospitals are full and no more beds. And California, for all the places, we thought we conquered the initial surge, like in March, April, May, and our government relaxed, and we all were saying that, we crossed the worst part, but then a new surge on surge hit us. Today, we have all our hospitals are full in California. We have 1,500 patients as of today in the hospital. 1,500 patients today in one day. Okay, so instead of going through the illness and management and prevention, I want to concentrate on something that many other speakers will be talking all about it. I want to concentrate my rest of the talk on newly released 2 days ago by President-elect Joe Biden, what's called American Rescue Plan. I've been a Republican pretty much long time, but recently I felt the present government of President Trump hasn't done much to the healthcare or prevention of COVID. And as a physician, I felt I needed to do something about it. So I joined President-elect Biden's campaign 6 months or so ago, and I have contributed substantial. I'm one of the major contributors. And therefore, I have a direct access to the president. And as a matter of fact, we talked to him twice, me and my children, and as late as yesterday. But of course, on the Zoom, like we're doing now, because there's no personal contacts here in USA. So, and also, like Adi mentioned, that I'm now, for this year, chairman of the American Federation of Hospitals. That means all for-profit hospitals belong to the federation, and I've been on the board for a while, and this year I'm the chairman. So I have some knowledge that's unique. Actually sent to a couple of friends, maybe to Astrazeneca Vaccine and maybe Dr. Malam, about the confidential draft that we received a week ago. And I don't know whether it's still confidential or it's released. But anyway, among friends, I don't have much confidential things that I need to avoid, because this is all good for the country. So American Rescue Plan is asking for 1.9 trillion from the Congress. I don't know how to translate into rupees. It might be as high as the total yearly budget of India, if not more. I don't know. Of 1.9 trillion, 400 billion has been allocated to COVID prevention, treatment, and further prevention going forward. Okay, let's talk about a few important things, because our time is of essence here. 20 billion of 400 billion is allocated to national vaccine administration through states, localities, including tribes. Here we have the tribes, especially Native Americans, who they call Indians, and other territories. They intend to establish community vaccination centers all through the country, and also mobile vaccination through vans and transportation through hard-to-reach territories. The next aspect is testing. $50 billion has been allocated to testing. They are budgeting a lot of resources to implement and develop and implement rapid testing, okay, so that we get the results much faster than sometimes it takes a day or two. And now it's getting better, but not everywhere. So that's what they're trying to do. And increasing the lab capacities everywhere, okay, so that we could test schools and local communities and other gathering places, so that we could like especially government offices, because there's a lot of people that will be there, and senior living centers, we call nursing homes here, and including prisons, because a lot of prisoners are dying because they're in very secluded locations, and not many prevent PPE, like patient protection equipment, is not available. The next aspect is creating jobs. Okay, they budgeted public health jobs, 100,000 new employees are public health workers, which is kind of 3 times the normal. So one, giving employment, and the second is to help prevent and care for COVID patients. And then we have a lot of disparities in this country, like I said before. Certain underserved communities, African Americans, otherwise called Blacks, and Latinos, and poor people, and communities where a lot of people live in one house. These are the areas that they want to identify and pay special attention to those communities, so the virus does not spread and ravage these communities and increase the death toll. And certain hotspot areas, like I said, senior living centers, and like I said, 40% of deaths so far are from those senior. Here we call them seniors, people about 65 years of age, and it may be different in India. Okay, and then to combat new strains, to sequence them and survey them and invent any new methods, including new vaccines for new mutant viruses that are coming up to American shores, probably from the United Kingdom and South Africa. And we're just testing them and knowing about that. We know very little about it to date. Okay, and then other important aspect is supplies, patient protection equipment. That means the masks, the gloves, and robes. These are important. They allocated $30 billion for this project. They would deploy National Guard. See, National Guard is like a semi-military agency that the government could call upon. These are not actual combatants in the army, but they are called on to address national emergencies. In here, which is they're calling it to address COVID, which is very unusual. And then they have allocated $10 billion to manufacture these PPE, protection equipment, here domestically, rather than buying them from outside. Right now we're buying a lot of the quantity from China, not much from India, maybe some, but quite a bit from China and other countries. And then treatment protocols, manufacturing, purchasing, and implementing therapies rather quickly. So that's another aspect. And then protection of workers, both frontline and workers everywhere. And they want to integrate global response, because recently President Trump came out, brought America out of World Health Organization, and President Biden will rejoin the World Health Organization right away. And then important thing is school reopening. The schools are closed pretty much for several months now, and nobody knows when they're going to open. So President Biden has allocated $170 billion. I mean, these billions don't mean anything, but I'm just reading out from the release we were able to receive. So they want to test and they want to offer PPE and vaccinate teachers, and therefore reopen the schools, which is very important because otherwise we lag behind in our studies and therefore talent and the jobs. Okay. And 35 billion has been allocated to higher education, like more scholarships to colleges and universities. And then comes certain controversial priorities of the Democratic Party as opposed to Republican Party. The Republican Party allocated $600 per week for jobless population, whereas President Biden wants to give additional $1,400 per week. That means $2,000 per week. What is the controversy about it? So the controversy is you're better off staying home than coming to work. If your salary is $72,000 or less, with $2,000 a week, it amounts like you could better stay home. That is the Republican argument. And therefore, they want to give incentive to people to work, come back to work. So therefore, they reduce the incentive to $600 rather than $2,000. And now the Democrats want to go back to $2,000. It's controversial. And there are many other controversial topics which are of democratic priority, and that doesn't apply to the people in this audience at the present time. So I differ that. And with that, I conclude my remarks because there are many other well-respected speakers here that you'll be hearing from them. This is my American perspective and my personal experience of COVID in the United States of America. Thank you.
Thank you, Prem. Thank you very much. So, okay, thanks. And we can, so if you can, is there any compelling questions? Only one question, since so you can't stay at the end with the questions, right, Prem?
I won't be able to stay. So one question
okay.
is fine, one or two.
One of the question they were asking, I think they were asking about Shiva from New Jersey was asking the Biden's plans, which you already elaborated. So I think that's covered. So the other question is how you handled the shortage of staff in your hospitals, especially in California and Texas.
Good question. That's probably a few $1 million question. I don't know. We're struggling. We have several ways we're doing. One, recruiting junior nurses from the school, which is unique for primary health care. Many of them are hesitant to recruit junior nurses, and which we're doing. And we're recruiting LVNs. LVN means a little lower than registered nurse, licensed vocational nurses, and then EMTs, emergency medical transportation personnel. And in addition to that, we are normal salary here for nurses is around, let's say, $40 to $70 an hour, $40 to $70 an hour. But we're paying now $250 an hour, okay, to recruit the nurses, and still they are in short supply. Okay, and then with regards to physicians, we're trying to shift physicians from one region to the other, but it's not working out well because it's very difficult for a physician that's in the community to leave the community and come here. And then the other measures we're taking is buying PPEs from any source we could get, from China. And I got, luckily, good supply delivered from India through our friends from Nata. So we're taking all those measures. But is this enough? No. The best thing is for us now to hope this surge in California will start coming down after 3 more weeks. Why 3 more weeks? Because people got tired staying home, and they got frustrated, and they left homes and went to visit the families, or maybe went to Vegas, and I don't know where all they went. But during these 2 consecutive holidays of long weekends, 4 days each, people have gone on to various places, and therefore we have seen increase in surge, which will go on for at least 4 or 5 weeks, and that would take another few weeks for it to come down. So we're hoping and praying that we will survive through these crises. Thank you.
Okay, thank you, Prem.
Anna, I have one simple question, Anna. Raghav Reddy. Anna, do you hear
Could
me?
you speak loud, please?
Anna, this is Raghav Reddy, Anna. So
Okay.
one simple question. So right now we are going in slow pace, Anna, in vaccination one. As a healthcare chairman and administrator, what are your suggestions, Anna, to make it
Okay.
faster,
Good.
quick?
Good question. I've been thinking about myself, what to do. In certain states, or majority of them, the governors have issued orders not to vaccinate the community yet, to vaccinate only the frontline workers. But nationally, I saw it yesterday, that Biden administration wants to open up vaccinations for everybody above 65, which is seniors here. So I'm a little disappointed that we are not able to give as many vaccinations. We gave 30,000 vaccinations in all 40 hospitals, which is very low. And a lot of people call me from the community, and they want vaccinations. It will open up. Short answer is it will open up. Very quickly it will open up. But there aren't enough supplies now. So Biden administration is going to get on this one right away. They have the whole team set to go starting 20th. 20th is the inauguration of President-elect Biden. And finally, at least Vice President Pence is cooperating with the transition team, which unfortunately President Trump gave up. And he just locked in his own house or a cell, and it appears like the president lost interest or lost probably his good senses. So yes, patience. The President Biden's 1 million shots a day in the arms of Americans. I don't think that will get us to where we want in the time period we want. So the projections now are we need to give 2 to 3 million shots a day. So, but Biden team didn't want to promise something more and fail in their first 100 days. So their mantra is they want to vaccinate 1 million, so 100 million by end of the first 100 days of Biden administration. So let's wait and see. Many of my friends call me, and I tell them, just give me a few days. I'll get you all in. And this will come very open starting in after 20th. It'll become very open. Thank you.
Okay, thank you. Thank you, Prem. Okay, so we can, in view of shortage of time, we can move on to the next speaker, unless you have any other comments, Prem.
No, I mean, again, thank you. It's a wonderful webinar that we have organized, and Nata is thankful and proud of you.
Thank
Thank
you.
you.
Thank you, Prem. Thank you very much. So the
Thank you.
next is Dr. Sudhakar Jonalgada, President of API, American Association of Physicians from India. He is going to introduce Dr. Nageshwar Reddy. So next I'll turn it over to Dr. Sudhakar Jonalgada.
Thank you, Dr. Aisha Reddy garu. Thank you very good evening. And it is really a distinguished honor to introduce premier outstanding gastroenterologist from Asia. And Dr. Nageswar Reddy is a graduate from Kannur Medical College. During his medical career, he obtained 9 gold medalists during his career. Subsequently, he did his MD from Madras Medical College, and later he did his gastroenterology fellowship at Postgraduate Institute of Chandigarh. His main interest is therapeutic pancreatic biliary endoscopy and transgastric endoscopy surgery. And currently, he is serving as chairman of Asian Institute of Gastroenterology and Hospitals. Dr. Nageswar Reddy published more than 700 papers and also about 20 chapters international books. And he's editorial board of GI Endoscopy and World Journal of Gastroenterology and several other journals. And he is president of Society of Gastroenteroscopy and also visiting faculty for more than 200 international endoscopy workshops. And he had several awards, but I'm going to give you a little most important ones. And one is he awardee of BC Roy Award, also Padma Shri and Padma Bhushan Award, and also Dhanvantari Award, and also Vajraratna Award, and Francisco Roman Award from the Philippines. And recently, he got award from Science called Associate for the Advances Science. It's my honor to introduce Dr. Reddy again. I can talk about the whole resume a whole day, but I brought some few highlights of his career. And it's really an honor to introduce Dr. Reddy again. He's going to talk about COVID-19 in Indian perspective. Please welcome Dr. Reddy.
Thank you, Sudhakar. I'd like to thank the Nata and RP for this very kind invitation on what's happening in terms of COVID vaccination in India. So what I'm going to do is I'm going to briefly talk on this current situation, which I think is very appropriate because, I'll share my slides. Yeah. Can you see my slides?
Yes.
Yes, sir.
Yes,
Yeah,
sir.
so I think this is a very appropriate time, at least in India, for this webinar, because just yesterday, we launched the COVID vaccination in India. The world's largest adult vaccination drive was personally launched by Prime Minister Mr. Modi, and around 3,000 centers were opened. This is just the preliminary part, and around 200,000 healthcare workers were vaccinated. So I think this is going to go on now. From now onwards, we are going to see a vaccination drive, which I believe is not only going to be the world's largest, but probably the world's most well-organized vaccination drive. I tell this because I've heard all our colleagues in United States and other parts of the world talking about the vaccination program. For some reason, although India is generally disorganized, when it comes to the vaccination programs, they're very well organized. The reason is that every year, over 29 million infants get vaccinated and about another 28 million pregnant women get vaccinated. The Indian polio vaccine is probably the most well-organized polio vaccine drive in the world. And in fact, 10 years back, we eliminated polio because of this. And we are presently headed by a health minister who's actually started this polio vaccine. And another important feature is there's a tremendous cooperation between the center and all the states, irrespective of the political affiliation, to drive this vaccine program. And for all these reasons, I'm very optimistic, although there are some issues or problems that I'll discuss as I go along. And before I actually start, I wanted to look at these very interesting curves of what is happening to COVID in India. You see this curve here is the present COVID situation. We peaked in September, little in October, and then started coming down. And you can see January 15th, the cases have come down to 15,000 per day with about 120 or 130 deaths, which is extremely low. We anticipated a small second upward swing somewhere in December, January. It didn't happen. And if you compare what happened in United States or in Europe, you can see the green one is the United States curve. You see there are actually 3 upward curves. And the third one, which has gone up now, is the present one, which is, as Dr. Prem Reddy said, creating a havoc in many parts of the United States. So you can see for some reason, India actually didn't get into this third wave or second wave even. We're just dipping down. Now, if you ask me why, we still do not know. In fact, it's not that we're very disciplined. You can see people around without masks. You can see that they're celebrating festivals. Just 2 days back, we had one of the largest assembly of people at Kumbh Mela. We had Shankranti, we had Deepavali, everything, but still it hasn't gone up. And of course, there are several hypotheses. And one of the things that we have found, a lot of work from our institution has suggested in peer-reviewed papers that's going to come soon, that we have a different type of native immunity. HLA epitopes are different in our people. And also, I think Vishnu would understand some of this, that in fact, the virus doesn't enter into Indian bodies because we have a special mutation in an enzyme which aids the virus to come in. So all these things are helping the Indians, but whatever it is, we are lucky. But I think we should push our luck further and see that this disease is completely eliminated from the Indian subcontinent. Now, coming to the topic itself, there are many vaccines that are now available. In fact, over 15 phase 2, phase 3 trials, but predominantly the ones that are being used in US are the RNA vaccines, the Pfizer and Moderna ones. Ones that are being used in India are these two vaccines, and I'm going to concentrate on that. The Indian vaccines that have been approved by the government of India on January 3rd were two. One is the Covishield, which is manufactured by Serum Institute, Pune. It's actually a so-called Oxford vaccine. And the second one is the local Indian vaccine called Covaxin, which is made by Bharat Biotech in Hyderabad. So let me just delve a little on these two vaccines, because for several reasons. One is there's been a lot of controversy in India recently, which vaccine to take, which is safer, and so on. Also, most lay people don't seem to understand the differences between these vaccines. And I know that a predominant audience here are not doctors, so I'll just try and simplify this. The Covishield or the Oxford vaccine, which was made in India in Pune Serum Institute, the initial research was done by Oxford and Astrazeneca, and then given to Serum Institute of Pune to make this vaccine. What they have done is they have taken adenovector virus, which is a chimpanzee virus, which is harmless, and into this they have put in the corona virus genes, especially the spike protein gene. So when this virus goes into the body, the spike protein gene starts producing the spike protein against which antigens are made. So this actual virus which is being injected is not a human virus, it's a chimpanzee virus, but it's harmless and has been used earlier in several other situations. The second vaccine, the Covaxin, is made by Bharat Biotech, and actually it was a symbiosis of Bharat Biotech with Indian Council of Medical Research and National Institute of Virology, which produced this. This is actually actual coronavirus, the COVID-19 virus, which has been made inactivated so that the whole virus becomes inactivated and it can't replicate. And this virus is injected into people, and there it produces an immune response. Now, theoretically, the immune response from this vaccine should be stronger, because not only the spike protein that's being given, like mRNA virus or Covishield virus spike protein, but you have proteins against the membrane, the M protein, the N protein, the E protein. So there are at least 4 proteins against which antibodies are produced in the body with this virus. And it's believed, but we still don't have proof, that compared to the other vaccine, this vaccine may actually protect against the newer strains, because against the newer strains that are coming up in UK or South Africa or Brazil, if you have a whole virus injected and a lot of immune response, then probably you'll have a better response. So this vaccine is interesting. Studies have shown it's very safe, but efficacy is the one which has become a little controversial. I'll come to that a little on, because there's a lot of debate going on in the public field and among doctors in India about these two vaccines. So these are currently available vaccines in India. If you compare the differences between these two vaccines, what are available in US and India, you'll see that the Indian vaccine is attenuated virus or viral vector. The storage is actually normal fridge, 2 to 8 degrees compared to -20. And this, I think, is of tremendous advantage in India, especially because this vaccine has to go into smaller towns, rural areas where you don't have storage facilities of the level that you need for the other vaccines. And the other important thing is shelf life for both these vaccines is almost 6 months. Whereas the shelf life for the mRNA vaccine is very short. In fact, Once you take out the RNA vaccine from the -20 or -70 freezer and thaw it, then you have to use it within 5 days. So, and also this makes a lot of difference in terms of economics, I think. The third, of course, lastly, the cost factor. You can see the cost is about $20 to $40. And of course, in India, in such a large scale, if you're doing it, especially if the government wants to give it free to a large section, then it has to be cheap. So this vaccine, both these vaccines are coming about $3. So again, this is a major advantage. And look at the short-term side effects. There's very little reaction to both these vaccines. Our institute has been involved in phase 2 trials of these vaccines. And what we have found is that in most of these patients, they just get a little local pain, not much fever or anything, and good antibody levels in spite of the fact they don't react to this. Whereas with both Pfizer and Moderna, we are now hearing that the second dose produces a little fever. I mean, not major things, but myalgias and so on. You might have to take a day off after taking this vaccine. Whereas with these vaccines that we have now in India, that is a very little reaction, and most of the people come back to work even the day after the vaccine. So I think this is a little difference between both the vaccines. Now, India is a hub of vaccine manufacturing, and this is something I think we as a nation are proud, and it's fortunate also because there are many manufacturing units in India which are making vaccines and distributing it all over the world with WHO, with Gates Foundation, with UNICEF, and so on. So we have 4 other vaccines in pipeline. Now, I'm telling you this because just 2 vaccines are not sufficient for population, require more. Of this, very actively, again, we are involved in many of these vaccines in our institute. Sputnik is a Russian vaccine, which is made out of, just like Oxford vaccine, adenovector, but this adenovector is a human adenovector, that is a human common cold virus into which the corona virus genes have been put in. That trial, we are actually doing a phase 2 trial, and phase 3 also is going to go on. Again, this seems to be promising with efficacy rates of 90%. Biological Evans has started what is called a protein vaccine, which is mainly against spike protein. Trials are going on, and again, by March, we'll start having phase 2. The importance of this protein vaccine is that it's going to be extremely cheap. You can even put it in room temperature in heat, it doesn't get destroyed. And in future, in long term, maybe this is a vaccine that India will have to depend upon. And even we're also having our own mRNA vaccine, which has just started now from Geneva. So you can see a lot of vaccines on the hub there. But what happened in India was a recent controversy, and this is because both the Serum Institute vaccine and Bharat Biotech's vaccine were studied by a specialized a group of scientists before government did approve it, and then they said these vaccines are okay. So the government approved this. The Director Control of Drugs approved this. Controversy arose because Bharat Biotech vaccine went only in phase 1 and phase 2. Phase 3 was ongoing, whereas the Serum Institute had phase 1, phase 2, phase 3 done outside India, and only phase 1 and phase 2 in India. So there was an angle that safety was okay. Safety is good for both the vaccines, but whether efficacy is tested. Efficacy, we know with the Serum Institute or the Oxford vaccine is ranging between 70 to 90%, with Bharat Biotech vaccine is 60%. These efficacy results are based upon immunological response, antibodies that are produced by the body. We don't have actual field trials which are going on. But the argument here was that you don't require field trials in emergency, because this was an emergency authorization of use by the government, and WHO has said that you can give an emergency authorization. If there's a pandemic, you don't have to wait for phase 3 trials results to come. So I think government of India did a very proactive thing by going in and giving permissions for these vaccines without a complete phase 3 in India, because of the need of these vaccines, especially because of the safety and because of the immunogenicity and efficacy shown in those vaccines that way. But the controversy came because these 2 institutes started fighting among each other, saying which is more efficient, which is more safe, and so on. And the element of Indian vaccine nationalism came in. Fortunately, the Prime Minister's office actually intervened in this case, and both have come together. And the happy story is that both are coming out with their vaccines now. So I just wanted to dwell on this, that there has been a little controversy. So there's been also a divided opinion in India between scientists and doctors whether without phase 3 we should have gone into or we should have waited because the cases are coming down. But I think the general opinion and view among many of the scholars has been that it's better to go in now, because if we get a very mutant virus which can't be tackled, then even these vaccines won't be useful. So if we can get the herd immunity up to a certain level, then probably we'll be happy to get over this controversy. So this has been a little controversy I thought I should explain. So this controversy has resulted in a little vaccine resistance. Vaccine resistance is a term you often very commonly use in the United States, but not in India, because the Indian people generally are very receptive to vaccines. And because we had a long history of vaccine program, elimination of smallpox, elimination of polio and all, people have seen they're very proactive, unlike what is happening in the West. But because of this vaccine controversy, and over the next 1 week, every news channel had these discussions on the vaccine, there seem to have been some amount of resistance cropping in. So we actually did a survey among 3 large hospitals in Hyderabad to look at what happens to healthcare workers, how they would take this vaccine. And you'll see very surprisingly, again, opposite of what is happening in the United States, that the more educated healthcare workers like doctors were a little resistance. 20% said we'll see what happens to others when they take the vaccine and then take it ourselves. About 10% said definitely no. We are a little controversial. The nurses were a little better. And what the lower healthcare workers, the less educated healthcare workers like the Safai cleaning people and so on, they were all very keen to take it. In fact, there very little resistance among them. Again, little different from what you see in the United States, but in general, this resistance has come recently because of this controversy, but otherwise people would like to take. So to overcome this resistance, a lot of us ran campaigns. In fact, at the AAG, we ran this very successful campaign of virtual run where we integrated health with the vaccine. 11,000 marathon runners took part in this. It was all India campaign. And we had many, many important stars, and we had a lot of sports people endorsing this. And I think this became a big campaign which suggested to people that they should go into taking this vaccine. So efforts have been made all over the country by government, by different institutions to break this vaccine resistance, and hopefully we will be successful. Now let's come to the actual vaccine implementation program in India. So what the government did was they set up 4 main centers, North India, South India, and the West and East, as you can see here. Into these centers were big depots where fridges were available, so that the vaccine from these 2 in Pune and Hyderabad were going transported so that they'll be stored. 31 sub-centers were created so that these vaccines would go into these sub-centers. And about 30,000 vaccination centers are going to be created soon. Each of these vaccination centers are going to resemble a polling booth. And again, India has a huge experience with elections every year. Every 4 years, we have this, 5 years, we have these huge mega elections where almost 1 billion people are voting. So using the same techniques, they're going to put up this 30,000 vaccination center, and then they're going to vaccinate approximately 3 million vaccinations a day. Of course, this is optimistic. We hope we reach these levels, because it's important to reach these levels of 3 million vaccination a day to quickly vaccinate all the people. And if the government of India program goes as they're planned, hopefully we'll reach this. There are going to be hitches, of course, but then we have to get through this. So what the government also did is that this vaccine is initially for healthcare workers, but everybody can now register in a Covet website, as I'll show you. And once they're registered, all the data is collected. And most of the time, the vaccine is done based on your Aadhaar card, which is a special identity card that Indians have, or they can use a PAN card also, but it's predominantly an Aadhaar card. Once you're registered and you're approved, then of course you'll be given on SMS on your phone which site you have to go for. Most of the hospitals are being used as sites, including government, private, and also schools, community halls, etc. Just like in an election, we're going to do this. So each area in this are going to be designated as, when the people come in, they're verified waiting rooms with enough space, the actual vaccination room, an observation room where people sit for half an hour, and an access to an emergency if this needed. So this is the type of arrangement that's going on. And of course, each of these areas are going to have 5 members. So there are already many members designated, vaccination officers who are going to check, authenticate that this is your Aadhaar card, because we don't want any frauds to happen like in the election. And once the vaccine is given, the crowd management becomes very important, how people are sitting distance, because we believe at least for 1 month after the second dose, you still have to follow all the precautions. Already, you can see here 1,50,000 auxiliary nurses and midwives have been deployed to do this. 150,000 people have been already trained to be deployed into this vaccination. And one of the things that the government did, which was good starting from early part of January, was to do several dry runs. We did several dry runs. In fact, several times the health authorities would come to hospitals, see how this is set up, go to schools to see how this is set up, so that people are already used to this. And this is, I think, one of the things that we learn from what is happening in the United States, where a lot of vaccine is available, but people are not getting vaccinated enough numbers. Some of the vaccine is being wasted because some of the healthcare workers are and so on. Whereas we're changing that a little here because of this dry run. We have had already 26 virtual meetings. There have been 61,000 program managers, 2 lakhs vaccinators, and so many vaccine teams have been. Again, as I said, there's been a very good collaboration between the state and the center, so that everybody is on the same page for this. So that once we start the program, it has to run very smoothly. As I said, everything else is unorganized in the country, but at least this is very well organized. And the government also has set up certain key principles for success of this vaccination, that is people's participation. So there's a lot of news, television, a lot of general social media, everything coming to the people, giving them information, so that the experience is just like election experience. We do the same thing whenever there's general elections, or whenever there's a universal immunization program like in polio. The other important thing is that ongoing health services should not be affected, because there's several national programs, several other vaccination programs going on simultaneously. These should not be affected. And of course, they should not be compromised on scientific and regulatory norms. Already there's been a lot of controversy about phase 3. So what the government did is that every vaccine person, especially when they're getting co-vaccine, have a very detailed pro forma, they fill it up, and then they followed up very carefully to see for any adverse effects. And I think a lot of this is driven by software technology that we're very strong in. Hopefully, some of this will work well. We know that you can have itches, but hopefully it will work well. So on January 16th, the government of India at a cost of rupees 200, which is maybe less than $3, got about 20 million doses to administer starting from the first day, which was yesterday. And as I said, 300,000 vaccines have already been given. Fortunately, top leaders in the medical field have started taking it, exhibiting to people that they have taken it. So what is the plan? In India, the plan is that the first vaccines are going to go to healthcare workers, which is approximately 10 million. Over the next few days, we would hopefully finish that by middle of next month or end of next month. And then we have the frontline workers, which are the police personnel, the home guards, the municipal workers, and so on, which is 20 million. So 30 million people are going to be vaccinated on a priority basis of the next 2 or 3 months. And then immediately once that's over, we're going to have those above the age of 50 years and those with comorbid illness, 300 million people. So by April, the government is expecting to finish this 300 million. This is going to be a little complicated, especially the prioritized groups, because of various claims. And the cost of vaccination for healthcare workers and the frontline workers, the 30 million doses, are going to be completely borne by the government. What happens to others, we have to wait and see. But the aim is that you quickly finish healthcare workers, frontline workers, and so on. There's been some objections here. For example, if you do the prison staff, what about the prisoners themselves? Are they not going to spread the disease? But there are complicated issues which can't be resolved very easily. But in general, an overall plan like this has been made. And what has also been done is this Covet digital platform that India has created. So in the Covet mobile, everybody gets this mobile app, and then you can actually log on to this. This is the homepage of the Covet facility web page that you can go into. They'll tell you about how to register for this vaccine and when you're scheduled. It gives you a reminder for the first and second vaccine. It also gives you reporting for adverse events. And after the vaccination is over, you can get an e-certificate of post-vaccine. I don't know whether they're giving this certificate there, but we have an e-certificate because you may require this further for traveling and so on. There are going to be problems, as I said. And in fact, if you look at this, the internet penetration in several states is different. Very high in Delhi and so on. More in southern states. But if you look at Bihar or northeastern states, the internet penetration is not so much. So there, in addition to Covet, we'll have to get other solutions. And other solutions are like what we do in election or the other mass immunization, that people have to go, health workers have to go door to door, have to notify. We've had some good experience with contact tracing during the COVID period using these type of health workers, the community service workers and so on. Hopefully they'll also be used. But as I said, this is the problem, that we can't be 100% sure that we're going to solve very well. But if everything goes smoothly, hopefully majority of the people can get access to this vaccination. So what is the plan, expectations from this vaccine program? Again, as I said, we may not go exactly in the expectations, but hopefully we will follow this to a large extent. And as I said, fairly well organized. The first vaccines have started in yesterday. Over the next few months, we are going to get other vaccines, because just these 2 vaccines are not sufficient. We require other vaccines to come in. And as I said, others are very actively into phase 3 also. And hopefully by April, we'll have 3 or 4 other vaccines, so that our vaccine pool increases and a lot more people can be vaccinated. And by April end, hopefully about 3 million vaccinations will be given. By July and September, we hope that 600 million vaccination, and hopefully by September, October, by later part of this year, we'll develop herd immunity. Now, why I'm concentrating on herd immunity is that in general, about 70% people have to have antibodies, 70 to 80% with some calculations for this COVID-19 to have herd immunity. But we believe, based upon data that we have, especially from some of the work that we have done in our institution, that herd immunity may be achieved faster in India, maybe 50% or 40% is sufficient, because of our native immunity and because of certain special features which seem to favor us against this virus. So hopefully by end of this late part of the year, we develop that and India would be free. And finally, I think, again, like to thank Nata and API for giving me this opportunity to show you some of what is happening in India regarding the vaccine. Looks very optimistic. This is an unprecedented situation. I think over the last 1 year, all our lives have turned upside down. There's been an effect on health, economics, socio-economic angles, and so on. And especially in a developing country like ours, the effects have been devastating. For example, in an unorganized sector, the labor have been hit very, very badly. And hopefully with this vaccine program, hopefully with more and more vaccine, with a very efficient vaccine program, we can overcome all this, and that we can come back to the root of economic recovery, come back to hospitals functioning normally, come back to our social activities soon. Thank you very much for giving me this opportunity.
Thank you. Thank you, Nagi. Excellent talk. As usual, you have so much command in whatever you talk, including COVID and gastroenterology. Thank you very much. So if you don't mind staying, can we ask questions at the end? Thank you.
Sure.
Yeah. Okay, thank you, Nagi. Okay, next we have another excellent speaker, Dr. Talwar, Arunab Talwar, and COVID and its vaccinations from pulmonary perspective. And Dr. Praveen Sampath, APNA president, will introduce Dr. Arunab Talwar. Praveen.
Hello, everyone. I'm Dr. Praveen Sampath. I'm a gastroenterologist practicing in Texas. I'm part of the time in a place called Brownwood and part of the time in Austin, Texas, which is my home. And we are in unprecedented times. As Dr. Nageshwar Reddy pointed out, we are living in the heights of the pandemic. Hospitals are flooded with COVID patients. ICUs are full. In fact, a lot of places there are no beds available. And the vaccine is right now available, and it's incredible to see how effective a plan, especially a nationwide plan, can be when I see Dr. Nageshwar Reddy presenting data from India. And hopefully we can get there and we can get many more people vaccinated here soon. Without much delay, I want to introduce Dr. Talwar. Dr. Talwar is a well-known expert in pulmonary and critical care medicine. He's a professor of medicine at Hofstra School of Medicine, and he's also a practicing physician at Northwest University Hospital in New York City. He's board certified in pulmonary critical care as well as sleep medicine. He's a graduate of All India Institute of Medical Sciences. He's been practicing, living, and without breaking much of HIPAA rules. I can also state that he's also experienced COVID. And he's going to talk about pulmonary critical care perspective from COVID and the vaccine administration here in the United States. without much ado, I present Dr. Talwar.
Am I to share my screen? Or Allah, are you going to share my screen, or do I put the slides?
Yeah, I will share my.
Okay, let's get started. Thank you for the kind introduction, and thanks to everybody for this kind of invitation. As I learned from Dr. Rao about what is happening in India, it's much impressive work that's being done there. I thought I'll take this opportunity to talk a little bit about the vaccine development here, how it pertains to us from American perspective. Next slide, please. You know, human beings, we learn from all crises. And the Boston Consulting Group had put together this report nearly like 2 months ago, that all crises lead to long-lasting changes. What do I mean by that? Like from 9/11, there were stricter aviation security processes put forward. There wasn't much resistance. People got used to it and accepted it. New policies were accepted, no problem. In World War II, when the entire workforce was actually sent over to Europe to fight, there was paucity of workers in this country. Women actually at that time joined the workforce. And since then, there's been an upsurge in women participation in all aspects of industry or what have you. Not much resistance. And similarly, the current SARS epidemic had opened up new opportunities, particularly if you look at it for the way we practice medicine with telemedicine, but also for the e-commerce, and which seems to have changed the way things are going to get done in this country and slowly across the world as well. But if this change of behavior has to continue, the virus has to be conquered. And for that, I think the primary prevention is probably the most important, because the treatment is expensive. Still, we don't have a good handle on it. And at the end of the day, as has been pointed out before, till the time we reach the herd immunity, and to reach herd immunity, I think vaccination is probably the most important aspect. I'm reminded of 1965 when the Surgeon General from this country, William Stewart, who's often quoted here in medical schools, had said that it's time to put a curtain on the infectious diseases and we can declare a war against the pestilence forever. I think that concept has been proven wrong one more time. 1984, AIDS virus, 2004, SARS-1 virus, 2009, MERS and its epidemic, and now we are going through the current coronavirus epidemic. Next slide, please. I just want to remind you, on the left-hand panel is this virus with its spike proteins, which even the medical students, or rather the high school students, know about. Coronavirus at this point has become the third common cause of death in this country. More importantly, if you look at the age group above 55, the number are exaggerating, are too impressive, and it continues to increase as we go down the age. So it is important that as we develop increasing treatments, or rather better treatments for this condition, we also pay a big attention to the primary prevention of this disease. Just like we do primary prevention for heart disease, aspirin cholesterol development, management for diabetes, et cetera, the same has to be the concept for this condition as well. Next slide, please. To me, the viruses, the war can only be won if we actually have a good implementation of the vaccination plan. I just want to recap for the audiences in this country that vaccines have saved tens of millions of lives in the past century, not only in this country, but the rest of the world. Let me take you a little bit worldwide tour of that. Next slide, please. So the most important thing that I would want to remind you that measles used to be a big epidemic in the last century. 1960s, when the measles virus a vaccine was introduced, look at what happened to the cases. It plummeted down right away. In 1988, there was an upsurge of measles in this country, and that's why the second booster was introduced. And see what happened. Suddenly, absolutely decrease in the number of cases, and the mortality has gone down. Polio has been mentioned before. In fact, it's one of the diseases that has been eradicated from the world, at least what the WHO claims. And If you study medicine in this country, you would be told that polio cases are unseen, and that is correct. And if you look at it, after the introduction of the polio virus, no more cases. The slide doesn't present here, but there has been gradual reduction. And at this point of time, polio is considered eradicated. What about pertussis? All kids get pertussis vaccines. See what happens. It goes down. We don't need to go too far. All kids get hepatitis B vaccine nowadays in this country, and see, once it has been started, the vaccination program, then HIV hip vaccine, the number has gone down. And recently, before coronavirus, the varicella vaccine was introduced for the elderly because it was causing a lot of infections amongst people in the elderly population. And the slides will show you that numbers have gone down. So folks, there is a big example that whenever the vaccines have been introduced and effectively given, it has changed the course of the disease for that particular process. Next slide. So what viruses have been eliminated in this world? It has been mentioned. I just want to remind you, only two, polio virus and smallpox. I want to remind you to the academicians here that SARS-1 virus has also been eliminated, but that was pure luck. It was a smaller virus. The epidemic was not as big, and something happened. The virus self-destructed. By the way, that was also coronavirus. And I hope everybody knows coronavirus, we've been dealing it for centuries. This is just one coronavirus that we have seen this time, for which we weren't that prepared well. Vaccines have helped us decrease measles, mumps, rubella, varicella, Ebola, yellow fever, rabies, influenza, and I can keep going down the list. But I have one prediction for people today, that one dose of vaccine or 2 doses of vaccine is not going to completely eradicate the current COVID-19 virus and its infection. No. Probably we are going to see an era, as from a pulmonary point of view, we would be needing boosters down the line. Some of it has been mentioned before, and I'll delve into the reasons for that as time goes on. So folks, get ready for this. We'll have to live with this virus, so we better prepare ourselves the best. We should exercise, eat well, etc., given. But at the same time, I think everybody should be getting vaccinated so that we can decrease the mortality and morbidity of this infection. Next slide. All right, so let's get to what is available in this country. Two vaccines are available. Both of them are mRNA vaccines, basically using an mRNA to produce immunity into the host. Both have equal efficacy, 94% for Moderna, 95% for the biotech Pfizer virus. Both are 2 doses, Moderna 4 weeks apart, Pfizer 3 weeks apart. It has been mentioned before, refrigeration with Moderna is a little bit easier, -20. We need a freezer storage, -70 for the Pfizer virus. That is why Pfizer virus is a little bit difficult to transport, and places which give this, they need to buy big pods so that they have this capability. So think about it, outside the cities where there are a smaller population, it can be a very cost-effective, prohibitive cost for the systems to give it. Same time, what are the side effects? Immediate side effects are minimal. There are maybe fewer children rigors with the Moderna vaccine. Arm pain after the second dose was a little bit more after the Pfizer viruses. The initial trial that was done, Moderna virus did not include any immunosuppressed patients and pregnant women. Pfizer virus vaccine did that, but to a certain extent. There were few cases of Bell's palsy in both of them, but after the education, it was determined that this was not directly related to it, but these side effects are being recorded as we go along. So maybe things will change, but it does not look like. Both are available, or at least were studied in Moderna in 18 years and older, and Pfizer vaccine in 16 years and older. So point that I'm trying to make is, yes, there are 2 very similar mRNA viruses. The efficacy remains the same. The 2 doses have to be given. Next slide. I put together here just to point out as to what happens after the first dose of the Pfizer virus. Just to recap and bring you to your attention at the point. Look at what happens after the first dose. At the 7th day onwards, the number of infections in the placebo continues to increase, but there is a sudden drop, and it remains the same, means there is no more increase in the patients or people who actually got the virus. So after the first dose, after the 7th day, the immunity starts to build up. Is it long lasting or not? I'll answer that in a minute. Next slide, please. Okay, but I do want to point out, there are multiple studies now from this country as well as from America, from Latin America, Argentina, for what have you. The efficacy of the virus is 95%, give and take, plus minus 2 standard deviation. That's a pretty high efficacy for a virus, for a vaccine that has been developed in a very short period of time. So point out that the mRNA viruses have helped us or will help us to tide over the crisis in this country, and they should be embraced by everybody. Next slide. Okay, so let's look at the Moderna vaccine. People have always have this comparison in their mind, what is one and what is better. I just want to show you the similar comparative data from the trial. Here, it takes 14 days for the curves to serve, the Kaplan-Meier curves to differentiate. The placebo people who did not get the virus continue to show infection as time passes, whereas those who got the vaccine, it seems to have stabilized. If you put that together, it's a 7 days in one and 14 days in the other. In the big picture, in the epidemiology, they are not much different. Next slide. Okay, some more things about the Moderna vaccine, because it takes, second dose is given after 28 days, and the Pfizer vaccine is generally given after 21 days. If you look at the initial data from this is after the first dose of Moderna virus. I said 14 days it takes to build the immunity. In the vaccine group in the first trial, 996 participants, only two cases actually developed the condition. And the control group, 1,000 people, 4 people got the infection. That's not that impressive. Next slide, please. But when we go to after the 14 days, starting 14 days after the second dose of the Moderna virus, means you got your full vaccine after 28 days and you got to wait 2 doses, 2 weeks more. See what happens. Of 13,934 participants who got the vaccine, 0, one more time, 0 people developed the infection. Placebo group, 13,883. This is a very well-matched study. 30 people got the infection, 9 had severe infection, needed to go to the ICU, etc., etc. If you look at the confidence intervals, the vaccine efficacy comes to around 100%, give and take. The point is, both vaccines are very effective. They generally will find that the vaccines are effective, even if when they are effective at 80% in epidemiology. These are the vaccines we have available, which are at 95% efficacy. There's no reason not to take these vaccines at this point of time, and that message should go across. Next slide, please. Okay, this part was discussed before. I'm going to give a different twist to it. Moderna vaccine, storage, minus 25 degrees, up to 6 months, a little bit more stable vaccine. Pfizer, it has to be frozen at minus 80 degree. It's up to 3 weeks after it has been released from the place from where it is gone. You have 3 weeks. Then when you have to take it out, the Moderna vaccine is stable for 30 days. Pfizer vaccine has to, both are stored at minus 8 degrees. When they reach the place where it has to be given, the Pfizer vaccine is stable only for 5 days. So folks, we have very little window and nothing can go wrong if you have to give these vaccines properly. You cannot make a mistake. And that is why from public health point of view, it is very difficult to manage this process because the stability of the mRNA virus is a little bit difficult. Moderna is a little bit more safe, but Pfizer vaccine is a little bit more difficult to handle. And once they are punctured, means once you thawed and opened the virus, you have only 4 to 6 hours in which you have to give. So you have to collect people, at least 5 for Pfizer vaccine, and 10 recipients should be available for Moderna vaccine so that it can be used. You will hate to see a vaccine which costs $30 a vial, but if you look at the transportation cost to some of the states, it will be much more. So the cost is actually not $30 per se, but a little bit much more than that, which the government is going to eat at this point of time. All we need to do is to convince people that it is worth the effort of the scientists and the community that has developed this vaccine at such a fast pace. Next, please. So what are the side effects I pointed out to you? The pain, fatigue, etc. are simple side effects. They do occur with many of the other things as well. Nothing much to talk about. Yes, lymphadenopathy is a unique feature of Moderna vaccines, and it does occur in people who are less than 65 years of age. It less in people who are elderly. You do feel a little bit of lump in your axilla, but it just goes away. Nothing needs to be done for that. It actually is a sign of immunity if you look at it from immunology point of view. Next, please. What is coming down the line, and it has been discussed before by Dr. Rao a little bit. Let me shed a little bit more light on it from our point of view. Astrazeneca vaccine, the similar one which is being given in India as well. It is also approved in UK, 2 doses, 4 weeks apart. It is stable at 2 to 8 degrees, lasts for up to 6 months in a refrigerator, easy to give. What was the problem from scientific point of view? When the first dose which was given, there were 2,000 people who actually only got 1 dose because of a mistake. The company actually declared it, and the efficacy was 90%. And after the second dose, the efficacy turned out to be 62%. Still being looked into as to why that is the response. But yes, it is a 62% efficacy after the first dose, 90% efficacy after the first dose, 62% efficacy after the second dose. It's approved in UK and Europe, and a version of that's being used by the Serum Institute as well. What about the Johnson & Johnson vaccine? Again, it's a DNA virus, put it into an adenovirus, as was shown by Dr. Rao before. It is a single dose. And it's being studied in 2 studies at this point of time, both for a single and 2 doses are being studied. It looks like the preliminary data that has been released looks very impressive for this. Interim analysis for this single dose was good. It was well tolerated. More detailed data is not available at this point of time. If the next virus that is going to get approved, next vaccine that is going to get approved in this country, probably will be the Johnson & Johnson vaccine. It will be more stable, more easy, and it will allay the fear of people who have concern about taking a new mRNA virus. Next, please. I also want to put on this out there that there is a 5th vaccine that is coming, folks. It is in phase 3 trial at this point of time. And in America, you need to do a phase 3 trial before you can get anything approved, even for an EUA. It is the COVID protein with an adjuvant. Now, adjuvant is, if you go to the medical school, you remember fronts, adjuvant. I mean, those is a product which takes the antigen so that the antibody can be formed. It is, the antigen in this is a matrix. It is probably made of polyethylene glycol. We all know wherever adjuvants are used, there is a little bit of more reaction, more side effects, more toxicity. More details are awaited. I don't have data to share with you on this point of time, but Novavax vaccine probably would be at least be in front of the FDA, at least looks like in March at this point of time, if I have to say. I'm not 100% sure about it, but people here, look out for this vaccine as well. This may be available to us. As has been pointed out, I don't think we will be just relying on one vaccine. Probably would be relying on multiple vaccines. It is also possible that from a pulmonary point of view, that we would be needing booster of these vaccines on an yearly basis. I'm not 100% sure, but at least it looks like that will be possibility. Why? Let's go on to that. Next, please. Just want to point out, pregnancy is not a contraindication. In fact, if you look at it, the American College of not gastroenterology, Dr. Rao, everybody's gastroenterologist, gynecology, American College of Gynecologists have also embraced this. This virus should be given. To allay the fear of the people, breastfeeding can be continued, but look at the comparative safety. If a pregnant woman doesn't take the virus, the vaccine, the effect of the virus on the lung, causing infection, hypoxemia, even if you do fine, hypoxemia is detrimental to the growth of the fetus. And that's how the message we have to put out, that at least it's even for the safe, it is safe for pregnant women to take it. Just put it in the broader perspective. A lot of women are frontline workers, not only doctors, nurses, etc. And we need to make sure that it reaches to them because it is safe to take this vaccine during pregnancy. Next, please. So what about the common theme? I'll answer 3 questions today because they are hot topic right now. There has been a mention of mutations in this. Does it increase the virulence? Does it increase the transmissibility? Transmissibility is ability to transmit from one person to the other. Does it become more infectious, as we call it? Or what happens? Are the current vaccines going to cover us against these mutations? Before I say that, I do want to point out all viruses mutate. It is their function. Viruses are nothing but a little bit of mRNA or a DNA covered with the cell wall. That is all that they do. They don't have to have family. They don't care for anybody. They don't have to put their kids to college. They don't have to take loans. So all that the COVID virus is doing is trying to find a host that seems to be human at this point of time and living in it, trying to replicate. That's all. We are at the other end of it, seeing the side effects of that virus and having all the complications. So the viruses will mutate. That is the law of nature. We cannot do anything about it. But let's see how we deal with these 3 questions. Next slide, please. I put together here a little cartoon, a diagram of the coronavirus. Outside there's a membrane, has been shown before. Spike protein, everybody knows what spike proteins are, which allows it to attach it to the virus, to our cells, and be able to enter into inside the cell and replicate. Dr. Vishnu, it will continue, not to worry. Okay, the spike protein has 2 separate receptors, one which allows to attach and the one allows to get in. I put together here a little genome of this. The problem is the coronavirus genome will continue to change or at least mutate. Next slide, please. Quickly, the first mutation that occurred was in February last year. Nobody ever talked about it. I want to show it that there was one mutation that occurred which resulted in higher infectivity, or at least that was the virus that reached America. The Chinese virus or the Wuhan virus initially was D614. It became D61G. Time will not allow me to dwell into the detail. I would not do that. But folks, first mutation appeared in February. So we have been dealing with this mutation for 1 year, folks. This is nothing new. Next slide. Just to show that initially in last March, everything, the D614G virus mutation was only in Italy. And in 1 month, it had reached America as well. So we have had mutant virus in this country before as well. Next, please. It did result in a little bit more infectivity, but did not change the severity. Next, please. So what I'm trying to make is that did it become more severe after that mutation? No. Was it a little bit more transmittable? Yes, it did happen. But that's why we need the vaccination program to take care of these kind of problems. Next, please. Because of the new mutation, which is VUI12 2020-12-01, which next, please, next slide. I'm trying to rush. It's now called the British wire mutation, which has 17 different, the virus has 17 different mutations, multiple of that in the spike protein. Next slide. Next slide. And I want everybody to remember the name. It is B117. And because of that virus, there is a little bit of concern that maybe we'll have a problem. But no, it is not a super virus. It will still be covered by the mRNA vaccines that we have now. What we are concerned a little bit, if it continues to mutate, these viruses continue to mutate, then maybe the spike protein changes its structure to that an extent that we may need a different PCR test and a different virus, a different vaccine. We are not there yet. It's a lot of time for this kind of thing to occur. till that time, if at all that ever occurs, because South African variant seems to be a little bit more mutated than the B117, I think, folks, we are safe with the vaccines that we have here and the vaccines that have available in India. Both are effective. And by the time in next 2-3 months, we'll have many more vaccines available, which will be effective against the mutant 101% as well. Next, please. Next, please. These are the groups that are being covered. Next, please. So what about the allergies? If you have severe allergies, you need to be a little bit concerned, but if the vaccine is being given in a controlled environment and you're being observed for any anaphylaxis, you're safe to take it. There is no problem with that. Next, please. If you have minimal allergies, there is no problem. The American College of Allergy, Asthma and Immunology has also released their guidelines endorsing that people with minor allergies can take this vaccine. Nothing will happen. Next, please. I want to stop here because for the shortage of time, and I want to make sure others get enough time to speak. So folks, I want to put it in the right perspective. How many people die of lightning in this country? 43 per year. Car accidents, 38,000 per year. Do you stop driving cars? No. Falling from a vending machine, the soda machine from which you buy your soda, 2-3 people die every year. Spider bites, 6 people. Shark attacks worldwide, 8 people. Falling from a tree while picking up coconuts, 600 people. How many people have died from COVID vaccine? 0. And to just put it in the bigger perspective for everybody, 5 cases over 10 years of major anaphylaxis of any vaccine in this country that have been reported. And you know, this data is very carefully collected by the National Institute of Virology and FDS as well. So the point is, we have vaccines available. They are new. They seem to be effective. They are effective against the mutant strains as well. Viruses will continue to mutate. Stay tuned. We are developing better medications for treatment of this condition. And so till the time we develop herd immunity, as has been mentioned before, the fastest way to reach herd immunity would be to continue to propagate giving vaccinations. I would stop here and I will wait so that I'll take any questions in the end, so that I want to have time for the other speaker as well. Thank you.
Thank you. Thank you very much, Dr. Talwar.
Thank you, Dr. Talwar.
Yeah, one thing I need to mention is it's not Dr. Rao, it's Dr. Reddy. Dr. Nageshwar Reddy. So
I have a little joke on that. I won't say it. I'll share it with you privately.
Okay.
Dr. Reddy.
I like a joke. I like to hear nice joke.
My apologies.
That's okay. He is a famous gastroenterologist, Dr. Nageshwar Reddy. Anyway, no offense. No problem whatsoever. But anyway, moving on. So the next speaker is Dr. Vishnu Chundi. You know, he is the one, I heard a private webinar like this, not a 10 people group. And he's the one who inspired me to try to arrange this kind of webinar. So I'm leaving the best for last, Dr. Vishnu Chundi, and introduction of Dr. Vishnu Chundi by Nata Advisory Council Chair, Dr. Mohan Mallam. They happen to be related, but that's nothing to do with selecting him as a speaker.
Okay.
So Mohan, please go ahead.
Good evening, everybody. This is Dr. Mohan Mallam. Before I introduce the next speaker, Dr. Vishnu Chundi, I will have one small announcement to make. That is one of the co-sponsors for this tonight's webinar. That is the APNA Foundation. So the APNA Foundation, the founding president, Dr. Astrazeneca Vaccine. APNA stands for Andhra Pradesh and Telangana Professions of North America. It is a 501c3 non-profit organization. And the mission of APNA Foundation is to enable community engagement in USA and in India. Launched in 2007, APNA promoted many activities, including health fairs, scholarship programs, and educational contents for students by name APNA WizKid program, WHIZKID program. The next WizKid program is scheduled for October 2021. And Dr. Atisha Reddy is the founding president, and now currently Dr. Praveen Sampath, who is here in our session tonight. He's the current president, and Dr. Padmaja, Millie in Kansas City. Kansas is the president-elect. And another thing I would mention is that several prominent leaders in ESA, both physicians and non-physicians, happen to be serving as advisors to the Apna Foundation. Thank you, Dr. Astrazeneca, for taking this initiative of organizing this webinar, which is very timely and useful for both physicians and non-physicians. I know you spend a lot of time in making phone calls, text messages, emails, and all that. So
Thank you.
Dr. Astrazeneca for course this event. Now we'll come to the real business here. Let me introduce Dr. Vishnu Chundi. As Dr. Astrazeneca just mentioned, Dr. Vishnu Chundi is my brother-in-law, but that is a different story. Dr. Vishnu Chundi is from Chicago area, and he's a specialist in infectious disease. And his parents come from Nellore, Andhra Pradesh. You know, those who are not familiar with Nellore, Nellore is a town in the state of Andhra Pradesh in South India. And Vishnu had most of his education in ESA, and he went to high school in Florida. He did his residency in internal medicine at Grant Hospital in Chicago. And he did a fellowship in infectious diseases at Rush University in Chicago. He is American board certified in internal medicine and infectious diseases. And he started practicing infectious diseases in year 1994. So he's a senior partner in Metro Infectious Disease Consultants. He's abbreviated as MIDC group, probably the largest infectious disease group, medical group in America. And MIDC has branches in several states in ESA, such as Illinois, Alabama, Kansas, Missouri, and Michigan. Their group carries a load of more than 1,000 patients of COVID on any given day. Dr. Vishnu Chundi has extensive experience in managing COVID-19 patients, and he also participated in several educational programs for physicians and non-physicians related to COVID-19. Currently, he is also serving as chairman of COVID-19 Task Force of Chicago Medical Society, which is also abbreviated as CMS. Let us welcome Dr. Vishnu Chundi. Thank you.
Thank you, Mohan, for this kind of introduction, and thank you, Nata, for allowing me to inflict my views on everyone here. I wanted to talk about the myths and reality of COVID, because as we round, one of the things I notice is all the questions that come up. And so I just wanted to quickly go through this. It shouldn't take too long because the time is getting late. One of the first big myths is that I hear, and even from physicians, is this RNA vaccines, they're going to alter my DNA. And that's absolutely not true, because these are some of the safest vaccines ever devised. And mRNA, the messenger RNA, simply goes into your cytosol within the cell, doesn't get anywhere near the nucleus. It gets into the ribosome and they start making proteins. In this case, there are two different proteins, one for Moderna and then the other one from Pfizer. The Moderna vaccine is the S2 segment. The Pfizer vaccine is both the spike protein as well as the domain area. So these have nothing to do with your DNA, so it will not change. And the mRNA rapidly degenerates, and so it doesn't persist forever in your cell. So it does not cause your DNA to change. And almost all of the reactions you're receiving now is from the nanoparticles of the pegylated of the polyethylene glycol carrier molecule. When the first RNA vaccines came out in the late 1990s and early 2000s, they were really designed for HIV and for tumors. They were giving basically all the RNA into the body, and it would get deactivated by RNases, and they caused reactions. And these nanoparticles of these polyethylene glycol allows the RNA to present itself inside the cell, and that's why you have the local pain in your arm. And then the reactivation of your lymph nodes and your germinal cells causes the lymphadenopathy, and the chills and the fever that you feel after the vaccine is because of your immune system waking up. So that's false. It does not alter your DNA. the next slide is basically what it does. This blue that you're seeing is the messenger RNA going into the ribosome and making the protein. And this protein that you're looking at is what is the antibodies are made up to. And the antibodies that you detect are not all the antibodies that are out there. These are the neutralizing antibodies are the ones that are important for viral inactivation. So that's what it does. And then the biggest myth that I hear, and you heard Senator Rand Paul, as well as several other people saying, well, why don't we just let everybody get infected? Because, natural infection is better and natural infection is safer. And that's an absolutely false statement. Natural infection is always, always, always more dangerous than having a vaccine-induced infection. That's why we have vaccines. Herd immunities induced by measles have very high incidence of side effect, including subacute panencephalitis and death. Natural measles probably wiped out the American Indians because they simply had no immunity. And by the time the Pilgrims arrived in this community into the North America, you had only 5 million people left because of the traders, the fur traders who were infecting almost all the American Indians with measles. So natural infections have significantly higher complication rates, and herd immunity by natural infections is not an acceptable solution for organized society. We would have not just 300, 400, 500,000 deaths, we would have multiple millions of deaths. So the paradigm is different for vaccines. Vaccines have to be incredibly safe compared to medications we give. All approved vaccines must undergo rigorous trials. So this is this is two examples of two of my patients recently. The 43-year-old gentleman I took care of about 2 months ago, he had basically 8 days of shortness of breath. He progressed to real severe illness, required this mask that is a torture device that Dr. Talwar uses to blow air into people, eventually required to be put on a ventilator and required ECMO, which is extracorporeal membrane oxygenation. And then we transferred him and eventually got a lung transplant. He's alive today. That's a 42-year-old guy who did not have many issues. This young lady I saw last weekend on call, she was 19 years old, came in basically like septic shock into the ICU. She had a faint rash on her legs, looked toxic for looking at her, she looked like she had toxic shock syndrome. And interestingly, we tested a COVID antibody on her, and the only thing that came back positive was a COVID antibody. And she had that multisystemic inflammatory syndrome, and with a short course of steroids, she eventually recovered and went. So even with what is considered a benign illness, where she didn't even know she was infected, it caused such a severe side effect for her with COVID. So natural infection is not safe. The other question I always get is, does the vaccine cause COVID? Of course it can't cause COVID, but this is something that you have to know. No, the vaccine does not cause COVID. It's made up of a small piece of non-replicating protein, and it's not a complete virus. It will not turn your PCR positive. It may turn your antibody positive because the antibodies indicate binding antibodies. They're not neutralizing antibodies, so they may turn your antibodies positive. Here's another myth. The vaccines have not been adequately tested. They were rushed into production. Well, that's not true. This vaccine has been as tested as any other vaccine. Prior to this vaccine, the vaccine that had the most rapid into production and giving it to arms was the mumps vaccine. It took about 4.5 years. This vaccine we were able to do rapidly, not because it happened quickly. These two vaccines platforms have been tested for about 25 years. The actual testing of safety has been unchanged. And this was covered by Dr. Talwar in excellent extent. And so these vaccines are absolutely safe. The reason why they were able to be rolled out was the government took all the risk of vaccine production. They said, okay, to the companies, we're going to pay you regardless of whether the vaccine works or not. And so 2 companies have failed. Both GlaxoSmithKline and Sanofi have failed with their recombinant protein vaccines, and they're not to be out till probably 2022 or later. And so the rapidity of the vaccines is because, interestingly, Zika. Remember Zika for all of those folks, which caused all of the birth defects? Well, the Zika vaccines were developed, and these by both BNT as well as Moderna, and that's how they became an accelerated development. And this is basically the Operation Warp Speed, which combined all of the 73 months that it normally takes to 14 months by overlapping everything, not by shortcutting any safety or efficacy data. So serendipity is a great word. Serendipity is how COVID-19 saved the two companies and possibly will put an end to this epidemic. Zika is a virus that was causing all sorts of birth defects, and there were two companies that developed this vaccine. Interestingly, look at this, Moderna and BioNTech. Now, why is that? They developed RNA vaccines to inoculate the world against Zika. And when they were all ready to push the Zika vaccine out, Zika went away. And the reason why Zika went away, if you look at India, India has everything to have Zika. It has the virus, it has mosquitoes, yet India didn't have a big problem with Zika. And that's because dengue, the other virus that's out there, all over India causing a big epidemic, is the same vector, which is Aedes aegypti mosquito. And the Zika virus cannot coexist with dengue. So the areas where Zika appeared, dengue also appeared and drove Zika out. So these people had two vaccines with nobody to give it to. But the platform that was developed was there. And then within a few weeks of SARS-CoV-2, the virus that causes COVID-19, the Chinese put out the whole genome, and within 6 days, the NIH discovered the antigenic portions and released it. And within 6 weeks, you were able to figure out which vaccine to give. And the NIH had a vast research trial experience and conducted the trial. And that's why the vaccine came out so quickly. The FDA approval process and safety requirements were unchanged for this virus, for this vaccine. But I'm not going to go into the slide because this is already done. So can you stop taking precautions if you have been vaccinated? And the answer is no, not until we have a significant decrease in the incidence of COVID in the community. You must still wear a mask and socially distance because you can still carry the virus in your nose and transmit it to susceptible people. So if you have an elderly person who didn't take up the vaccine, you can potentially harm the elderly person living in your family. Another myth is if I had COVID, I don't need to get vaccinated. And that's not true, because even if I had COVID in May, in April ending, and it wasn't that severe for me, luckily, but I still got vaccinated 2 weeks ago. I got my second dose 2 weeks ago. It was not easy. It does make you feel pretty tired, but it's because your vaccine, your natural immunity from the natural infection wanes. The RNA vaccines probably have a much longer longevity as far as giving you immunity. And so about 20 to 30% of people who get admitted to the hospital will not generate an antibody response. And binding antibodies do correlate with neutralizing antibodies, but they're hard to measure. The other myth is COVID-19 affects people because of their genetics. I know India, Africa, if you look at the world where the high incidence rates are, the high incidence rates are wherever there's cold. Africa, India, Asia have a much lower incidence of death hospitalizations. And there's epigenetics that are being looked at that Nagi's group is looking at. But I think this is not going to be borne out to be absolutely true. I think inoculum has a very important determinant. In cold countries, people have houses that are completely closed. I'm living in a house that the air has not changed in probably 2 weeks. So anybody who walks into this house, if they're sitting there, the air that we're breathing is their air also. In India, Africa, and other countries, people generally have fans blowing, their windows are open, and their incidence is and the amount of virus that you breathe in is less. So I suspect that has a major determinant for illness. A high inoculum, as we saw in HIV, if somebody got HIV through blood transfusion, they were usually dead within 3 years. If they got it through sexually transmitted ways, the HIV patients generally lived to 10 years before they became symptomatic. So the younger population also is driving a significant amount of lower mortality in developing world. The younger population generally tolerates the virus much better than the older population. So the viral characteristics have not been shown to play a major role in morbidity and mortality of this illness yet. So there's a difference between Black people and white people. This is the vaccine. This is something I hear all the time when I round in Chicago. Are you going to give me the white vaccine or are you going to give me the Black vaccine, doctor? And believe it or not, this has to do with what's considered a postmodern society. So in India, and as well as in developing world, people have a real experience with vaccine related illnesses that can cause problems. So they saw their own family members suffer from polio, diphtheria. The developed world has not seen this in over 2 generations, so they've forgotten. The other thing is there's been a tremendous amount of discrimination towards African Americans and people of color, and the Tuskegee trials and all of them have created a great deal of distrust towards government and health officials and other authority figures. So there is no black vaccine or white vaccine. There's only a single vaccine, and that's something that has to be reiterated over and over again. COVID vaccine increases risk of fetal loss, and that's absolutely not true. This is something that's all over the internet right now, that you shouldn't get vaccinated because you're going to lose your baby, you're going to go into preterm labor. Dr. Talwar clearly pointed out that the COVID infection itself increases hypoxemia, increases fetal loss. ACOG, as well as the Society of Fetal Medicine, advocates offering vaccine to pregnant and lactating women. So that should be absolutely encouraged. And then the other myth that's out there in the internet is COVID vaccine injects a tracker chip. This, by the way, is a huge thing on the conspiracy websites, that you're being tracked after you get a COVID vaccine by the government, and they will track you down. So the question becomes, who do you trust? Well, interestingly, people trust their doctors. They trust nurses. They do not trust elected officials. I know it's shocking, but people don't trust their politicians. And so the most important thing, and they also trust the clergy. They trust the pastor in their church. They trust the religious people in their community. So the Chicago Medical Society has started a trusted messenger campaign, and this involves physicians, celebrities, social influencers, and very specific to communities. So these trusted messengers are going to understand what the mRNA vaccine is, and comfortable communicating with their patients and their congregations. They should become an expert and be armed with knowledge so they can explain the myths and fallacies to convert the vaccine hesitant to the vaccine acceptance group. Interestingly, Nagesh Reddy, who I've known for many years, and everybody's related in India, and as I have to Nagi, he's a gastroenterologist, and one of the people who has absolutely created this big anti-vaxxer movement was a gentleman named Andrew Wakefield. And Andrew Wakefield was a gastroenterologist who first published in the Lancet in 1998 falsely that the measles vaccine was associated with autism, and this has become a huge movement. And hopefully, Nagi's working hard to get the GI people back in the vaccine camp. So we really want people to become experts in this field, not just the doctors, but the nurses, the people that trust their communities. So trusted messengers are people who act when they trust the messenger, the message and the motivations. This is really important. You must use the correct messenger. The most effective messengers are experts and trusted leaders in our own communities, both geographic ones and digital ones. Examples of trusted messengers are local physicians, school nurses, pastors, community leaders, and interestingly, in the African American community in the United States, barbershops. Barbershops are a major area of dissemination of knowledge. And context is really important, political, social, and experiential context. Abhijit Banerjee, who won the Nobel Prize for Economics in 2019, really understood the effect of peer effect. So peer effect is real and it works. Getting the word out, agents of change, where everybody's talking about the vaccine is important. And this type of message tonight, conducted by Nata, is really important to get the message out to all the audience out there. So please go to our website, which is vaccinetrust.org. If you want to volunteer to be a trusted messenger, we will get you the slide series. And I'd like to thank everyone for participating in this. It's 9:58, so it's getting late Central Time. So thank you. I will return this. I am done with my presentation.
Thank you, Vishnu.
Thank you, Vishnu.
Excellent job. Very passionate speech, passionate talk. So thank you. So I know it's getting late, but still there are some questions. We probably should continue. And if somebody is pressed for time, they can step aside or log off. But hopefully people will stay because this excellent group of audience speakers are there. So let me go ahead and start without delaying further. So already we talked about the variant. So whatever vaccines we have, they are effective against the variants at this point. So future, we'll wait and see. So the next question that came up is some internet is coming out, but I didn't see any national news, and none of the speakers talked about it. So what I'm talking about is 23 elderly people died in Norway after first dose of Pfizer vaccine. So what is that? What do you all know, and what is your comment on that?
Actually, BMJ, Adi
Yeah.
Nagi,
Now, go ahead,
BMJ just published a report on that. This was actually confirmed 10, but 23 was what the social media is going about. Now, these were all it's actually in the BMJ. Otherwise, social media, you can't believe nowadays.
Yeah, that's right.
Yeah, what the BMJ report said was that these people were very elderly. In fact, some of them were in the terminal stages of their life because of some other reasons. They were in a nursing home, and when they had the vaccine and fever and diarrhea or something following that, that seems to have sort of been the terminal step to take them off. We don't have a very detailed report on that. This is just the initial BMJ post that came in. Actually, it came in this morning. So I think we are not sure what exactly happened, but it looks like from what they reported that in very elderly, very sick people in the terminal part of the life, anything that can produce a small reaction in terms of fever also can push them off, and this was what happened. But I think we have to wait for a further detailed clinical report, and there's investigations going on in this area.
Thank you.
I like to point out that from epidemiologic point of view, unless and until there are clusters, means similar thing you see in other places in the same age group, maybe then there is a causality. Otherwise, it is very hard to pinpoint in one specific area, in one specific group. Now, Norway is the only place which is trying to give only one dose, and they don't discriminate. And these people had a lot of immunosuppression going on because of the age-related and other comorbidities affected. So hard to say. And it's being monitored by Pfizer, and they're going to come back with this thing. So please don't get dismayed by this. This is not something the vaccines are supposed to do. And hopefully people will understand that.
Thank you. So, Vishnu,
and
go ahead.
I'd like to point out that the studies were done with over 70,000 people, and the death rate did not exceed what was expected. Nobody died of the vaccine. Thus far, 10 million doses of both Pfizer and Moderna have been given. There's been no mortality. There's one reported mortality of a physician, possibly from ITP. Whether it was pre-existing or not is unknown. That's being worked out. So until you know more exactly about what the mortality cause was, I don't think it's wise to sit here and say, well, this many people died of the vaccine. I think they probably died of other comorbids.
Understand. Okay, thank you. Thank you for your comments. So bottom line is it should not deter people taking the vaccination. So you should go on and take the vaccination. That's what all our experts are saying right now. So the other question is from Mr. B. Reddy from New Jersey. Yes or no answer from the faculty or panel. Pfizer or Moderna vaccination, which one would you take if you have access to both of them?
Compared the both for you extensively for the same reason, and I showed there is no difference whatsoever between the two. The developing platform is the same. The efficacy is above 95% for both of them. Side effects are both the same. I showed you 3 Bell's palsy versus 4 Bell's palsy in thousands of cases, and put together at this point of time, more than 100,000 people have taken the vaccines. So my answer is whatever you get, you should take it. The earlier, the best. That's all.
Okay.
There is a minor difference between the ages of over 65. Pfizer seems to have a little bit more efficacy than Moderna, but that should not change anything. Whichever vaccine you get, you should take it. My father is 87. He got the Moderna. I said, take it.
Okay.
Mr. Pfizer took Moderna.
For above 16, Moderna is above 18.
Yeah.
That's the only other difference.
I think CD8 response is a little low for Moderna. That's what I heard, but that may not have any relevance clinically. So next question I have is, I guess Vishnu already answered. So even if you get vaccination, you should still wear the mask. So those who got the vaccination, can they still transmit the infection? The answer is yes, I think, but any additional comments?
Yeah, the measles vaccine is an excellent vaccine. It is a gold standard for all vaccines. Measles vaccine gives you about a 97% protection. Yet even people who take measles vaccine, they've clearly been documented to carry measles in their nose for a period of time. Thus, you must wear a mask until the incidence and prevalence of disease is low in the community, and then we can be mask free.
Okay. So
I
this,
have one question. Then I have one question.
yeah, go ahead, go ahead.
After 2 vaccinations, how long these antibodies is going to stay in the body with the same level, not decreasing?
Let me answer that. The Pfizer and the Moderna are mandated to follow their cohort for a long period of time. At least initially it was 1 year, but they have said they will follow these patients, not patients, these participants for 2 years. As of now, the Pfizer data is available for 6 months, and it shows the antibodies are still there. Will it be there for 1 year? I don't know, but I've already pointed out, I think we will all be looking for a booster at that point of time. So that question should not deter you from thinking whether I should take it or not, because at least if we can go for another 6 months and we can get the herd immunity to 70% to 80%, I think we'll be in a point where we'd have actually controlled this epidemic to a great period effect of time. So I think please feel comfortable that the effect at least is for 6 months, and they are going to release data about 1 year, and it looks like it will be effective at that point too, but I cannot say that. I have not seen that data.
The infectious disease world believes it'll be at least for a year, but the data are not out there. The other thing is, even as the virus, you get escape mutants from this virus, the RNA platform can be basically changed within 2 weeks. So the vaccine manufacturer can be changed within 2 weeks. So you'll have effective vaccine, and the booster would include that escape mutants that are out there.
Yeah. The Indian data that we have is 6 months. We have definite antibodies. They start coming down. But I think the other important thing is that there's also T cell response, which seems to be more for long term. So even if your antibodies are low, you may not get an infection because of this T cell response. So I think that's another factor that we'll have to look into.
Right, and the big data is from SARS, the original SARS infection, which are both beta coronaviruses. So 12 years after SARS-CoV-1, the original SARS, people still have antibodies on T cell responses. So this is a long-lasting immunity.
Thank you.
Yeah.
So
we have one question regarding the website and registry. So maybe this is for Dr. Vishnu Chundi. So as Dr. Nagesh Reddy Garu said, there is a registry website or mobile app like Covet in India.
in India.
Do we have similar registry in USA, or
No.
are you expecting some kind of similar registry in USA?
No, we've been in conversations with actually the incoming Biden administration, that Vivek Murthy group, and there is no uniform platform. India has done 100 times better job than the United States has done in rolling out this vaccine, because India has lots of experience in this, and they have chosen a unified platform. Here, it's up to the state, the county, and the municipality. So this is a true balkanized way of giving vaccinations, which will not work until they get their act together. When they do that, only God knows.
Microsoft, Oracle, and Salesforce are putting together a vaccination record system, which everybody will be able to have, so that we can use it for traveling, etc., etc. It's being developed as we speak.
The problem is,
This is Mohan Ramreddy. You need to check with your local, the county, the public health department.
Yes.
So that one is different. For example, here in our San Bruno County, they just published it today, the number to call about the vaccination thing. And also there is a website that you can go and register for the vaccination when you're going to get, depending upon the place you live. So the best thing is to contact your, whatever the county you live in, the public health department, because it is different for each area. And for our county, it just came today, where to call and where to look in the website. So that may not be useful for if you guys San Bruno County in California. And I have that information if anybody living in San Bruno County wants to know that.
Yeah.
Okay.
As Dr. Vishnu said, I think it is here is like bubbles, small areas like pharmacies. In Texas, for example, CVS and Walgreens, they are trying to start registrations, like local pharmacies called like Brookshire Brothers. So they have their own websites and asking people to register on those websites.
So bottom line is there is no national registry. Yeah.
Right.
County public health department is the best to contact them. Yeah.
Bottom line, India is well organized and we are not organized.
Well,
Yeah,
I think
that's correct.
I
Yeah,
think,
let me move on to some more questions then. Let's move on. So this question is from Lata from Virginia. This primarily for Dr. Nageshwar Reddy. Why is the less mortality in India? I think Vishnu touched on this also, but Nagi, can you answer that?
I think there's several factors which are causing decreased mortality. One, of course, is the age group, which seems to be much less than what you have in Western group. Obesity is much less. I think one of the important factors for mortality is obesity, which is much less in our place. And of course, the other factors like what Vishnu mentioned, there's not so much indoor compared to outdoor ventilation that we have here. But I think a very important unknown factor that's being explored is that initially we thought immune responses. So there's a lot of work which was done in terms of interferons, T cell responses, and so on. But there seems to be some new evidence coming in that the epitopes you have on the immune cells are a little different, and therefore the reaction to the virus is different. And most important, in my opinion, is that there's an enzyme called TMPRSS2, which actually increases or aids the virus from coming into the cell, into the epithelial cell. So in 50% of the Indians, this TMPRSS2 is mutated. We don't know why this mutation occurred, but it's mutated. And therefore, this becomes a very inefficient way for the virus to come into the cell, so it's protected. So that's the reason why I think we have less severe infection and also less mortality. There may be other factors. There's a lot of work going on in this area. We're still not sure. But for some reason, definitely, mortality rates, for example, mortality rates now have come to about 1%. And in our own place, it's 0.5%, which is very well. We're definitely blessed with that for some reason.
Good, thank you. So this quarantine, people traveling to India, so is that going to be lifted, do you think, after vaccination?
Yeah, so right now, quarantine is mainly for UK, people coming in from UK, not so much from other countries. Initially, when we started, there was a very strict quarantine. People had to stay for 2 weeks in a hotel and then come in, but it's lifted now. Only for UK it's there. Once the vaccine program starts, I'm sure it's going to be further. But also, I think in India, people have many ways of escaping this quarantine. It's not so effective.
Okay, yeah, that's right. Thank you.
Dr. Reddy, I have a question for
go ahead,
Nageshwar Reddy. We're talking about this virus becoming endemic and staying on for a long time, and that requires yearly vaccination. And that becomes even more of a challenge, especially if it's a 2-dose vaccination every year. And even here, for the flu shot, it's been a problem. You know, I mean, in the hospitals, we take it because a lot of us can't even work now without getting proof of vaccination. But in the community, the vaccination is really not widespread. It's not well penetrated. I'm just wanted to hear your perspective, especially in India, if it has to be done yearly.
Yeah. So Praveen, that's a good question. First of all, of course, we really don't know whether we're required to have a yearly vaccine for this virus or not. Only time will tell us. But I think if we do require a yearly vaccine, I don't see it as a problem, because what's going to happen is the costs are going to come down further. And we are all used to this yearly vaccine in India in terms of pregnant women, children, and so on. So the whole setup machinery is already there, and the mentality of people is also, in fact, many of them actually write down the exact date they had the vaccine so that they can go and have it. In fact, even the flu vaccine is becoming very popular here. A lot of us take it yearly. So I think yearly vaccine in India is not going to be a problem, but I still don't know whether we require it for this virus, whether immunity is going to be better. The second thing is, I don't think yearly vaccine will be 2-dose vaccine. I think some of the vaccines that are coming, for example, Johnson is already a single dose. And the protein vaccine, which is, again, I think one of the companies in India is strongly onto the protein vaccine, also may be a single dose. So I think it may eventually be a single dose if it comes as a yearly vaccine.
Thank you.
Thank you. I think Moderna CEO Stephen Bancel, I think, gave a statement that COVID is going to become endemic, and we have to deal with the virus for the rest of our lives.
But Dr. Astrazeneca, already you have 2 COVID beta coronavirus, HK07. There's a second one that's been endemic forever. The first one was in 1890, the first outbreak. probably killed millions of people, and all viruses mutate. It becomes less pathogenic, and we learn how to live with it. That's what's going to happen here. It's going to become the common cold over time.
Okay, thank you. So post-vaccination precautions, can you take non-steroidals? And then there's any reason to test antibodies after vaccination? And any info on the antibody response? I think you already answered that. So can you take non-steroidals? A lot of doctors also don't know. So they take non-steroidals after vaccination if they get pain or fever and all that. So
sure, and then Nagi can scope you right away afterwards when you bleed.
we have enough business without scoping vaccinated patients.
Gastroenterologists in the panel here.
We have plenty of business even without endoscoping all these vaccinated patients. So is the vaccine becomes less effective? I think with steroids it becomes less effective, right? So with the non-steroidals, should you take non-steroidals or should not take non-steroidals after vaccination?
There's no evidence either way.
Tylenol you can take.
Yeah, you can take
Tylenol, yeah.
Paracetamol
in India.
Paracetamol,
See, the fever and the chills and rigors are part of the antigen antibody reaction. Why mess with it? If you can tolerate it, maybe you should not take anything. Tylenol is better than NSAIDs. That's what my personal opinion is. There's no data to back this up.
I agree with that. When AstraZeneca started their trial in UK, when they're doing the trial, all the recipients were routinely given paracetamol, everybody. And that was a little criticism about the trial, but everybody was routinely giving paracetamol, all the recipients. So you could use paracetamol probably safely, but there's no need for other things, I think.
Yeah, okay. Okay, thank you. So any benefit of taking, of course, the data is still out, I guess. Any benefit of taking another vaccine, such as vector-based AstraZeneca vaccination after you take Pfizer or Moderna vaccination earlier?
Different vaccines. See, the original adenoviral vaccines were HIV vaccines. They use human adenovirus. The problem was the human adenovirus, we've all had adenoviral infections, so the uptake rate is lower with human adenoviruses. So they use a chimpanzee vector because we're not chimpanzees. At least some of us are not. So the chimpanzee vector virus seems to be more effective. These are two different vaccines, so you could conceivably take the other one without a problem. One of my pharmacists developed a sensory neuropathy with demyelination of small fibers from the Pfizer vaccine, which we've reported. So we're not going to give him the vaccines that have polyethylene glycol, and we're waiting for the Johnson & Johnson vaccine because it will not have that component in it before we vaccinate him.
So for the second dose, for his second dose, right?
The whole new series. You can't mix. You cannot mix the two vaccines. They're two different vaccines.
No, but I thought he got the transverse myelitis after the second dose.
No, it's not a transverse. It's not a transverse myelitis. It's a sensory neuropathy. It's a small fiber neuropathy.
I see. Was it after the first dose, right?
After the first dose.
So he didn't get the second dose.
No.
Let me answer this. There is some thought in those who develop vaccine that maybe the adenovirus vaccines will have a better T cell response. There is a thought, and scientifically probably it is correct, but the data needs to be seen. As has been pointed out, if you look at the T cell response of Pfizer and Moderna, they do lead to T cell activation for this, which is important for long-term memory and long-term protection. But we have used adenovirus vector vaccines for such a long period of time for so many diseases, and they are effective. So we'll have to see what is the T cell response for these vaccines, single dose vaccines that are coming. Maybe they will be more effective. We don't know. We'll have
also, this adenovirus vaccines, vector vaccines are better against mutations, right? Is that what the theory?
Yes.
Against mutations.
Yeah, but at the same time, as been pointed out, the Moderna came out with the declaration that their platform can be changed in 2 weeks to bring a newer vaccine as well. So how much of it is hype and how much of it is, I don't know.
Adi, this is a little. The adenovector vaccines, which are using either human or chimpanzee adenovector, They are mainly spike protein is put as genetic material. So the response is against the spike protein. But the one which is supposed to be more effective against mutation is the whole inactivated virus, like the co-vaccine, what is made in India. Because there you have the whole vaccine. And like Dr. Talwar showed earlier, there is a protein response to not only the spike protein, but the M protein, the N protein, and the E protein. So hopefully if mutations occur, it doesn't occur in all the proteins. And therefore, this vaccine is theoretically supposed to be better. We don't know still. But what has been shown is that T-cell response. This is a very nice paper in Lancet, which has looked at T-cell response with the Oxford vaccine and showed that the T-cell response is very good, even after 6 months. Whereas with the inactivated virus vaccine, there's some preprint reviews, not yet published in peer review, showing that the T-cell response is there for very long. So there may be a difference in T-cell response, both for adenovector and the inactivated virus compared to just the mRNA. And mRNA vaccines are so new that we're still starting to learn more about what the response are going to be.
I have one question. So what if the person takes both Pfizer and Moderna, both vaccines? Is there any issue?
Yes, there is. You can take both. You should not.
You should not. Okay.
If you get the first dose of Moderna, you take the second dose of Moderna. You get a first dose of Pfizer, you get the second dose of Pfizer. That's how the studies were done, and that's how the data is. So we should just follow how it was done.
So even by mistake, if they can go and just take both of them the first dose by mistake, or maybe somebody greedy and they want to take like, okay, maybe it will cure more, and they take
double benefit.
Yeah. I don't know. I don't know about that.
We would not recommend. They would not. This panel would not recommend it. Yeah. Okay.
Other people take the vaccine.
Pardon? I have one more question.
Yeah, go ahead, Raghav.
For audience sake, after first dose of vaccination, how fast these antibodies is going to develop? And after second dose, so what is like a full effect of antibodies? How much time it takes?
I showed you the data that with Pfizer within 7 days after the first dose, Moderna 14 days after the first dose, and 2 weeks after the second dose, you have enough antibodies with both of them. But still does not take away from using the mask and social distancing.
That's right. That's right. Yeah. Thank you. So what about if you're infected with COVID and do not know that you are infected and unknowingly take vaccination? I think still they get immunity, I guess, right?
Yeah.
Correct.
Yeah, they do get the immunity, but it is recommended that if you have had a vaccination, either from influenza or let me cover this, flu or the pneumovax, you should wait for 2 weeks. If you got the monoclonal infusions for COVID, you should wait 90 days. But if you had just COVID, you should wait at least 2 weeks before you take the vaccination. But inadvertently, you were asymptomatic carrier and you got the vaccination, nothing will happen. Maybe the local and the immune response may be a little bit more robust at that point, but nothing much will happen.
So I've had several residents of our house staff who we gave vaccine to, and then they tested positive in between. And the evidence does, basically I said, go ahead and take the second dose because there's no evidence that it harms you. So basically you take the vaccine.
Okay.
What is this?
Okay.
Okay, how many more questions, Sister Reddy?
Okay. Yeah.
Yeah, I have one question. Actually, I have so all the others are answered. Only one question is left from my standpoint. This was asked by Ashok from New York. Damage to lungs due to COVID. This is for Dr. Talwar. Is it permanent or any follow-up, including follow-up X-rays on these patients who had lung involvement?
Yeah, we're studying that very actively, actually. I just published on this as well. Yes, the ground glass appearance and reticulations, we are worried that in some of the patients, it's going to lead to significant fibrosis. And we have seen patients for that already. So a small subgroup of patients will not resolve their lung damage. They will be left with some changes in the lung, which we call as pulmonary fibrosis, which on restriction will look like a restricted lung disease. In simple words, patients will be left with baseline shortness of breath on exercise. That is a possibility. What is the treatment for that? That's maybe another time I'll talk.
Thank you. So any parting comments from the speakers? Any parting comments?
Yeah, one more, Andy. I have one more final question, maybe.
Okay, go ahead.
So this is from Dr. Banoji Reddy from New Jersey. So he's praising the doctors. Doctors are warriors, and you were in the front line helping COVID patients initially, and now you are leading and taking the vaccines now and building the confidence to normal public. I know it's too early, but are these vaccines going to be like flu vaccines, which you need to take every year?
I think we already discussed this. I think we're still not.
We went through that.
Yeah, I kind of gave you my bias on this already.
Maybe.
So last question is, if you take a flu vaccine, can you take immediately COVID vaccine, or do you have to wait for 2 weeks?
No, you have to wait for 2 weeks. Any vaccine, you have to wait for 2 weeks.
Okay.
That's from CDC.
That's because you're actively making antibodies to it, and you'll block the vaccine uptake. So you should wait 2 weeks.
So any parting?
Mohan, I would like to take this occasion to thank Allah Ramreddy, who is on mute. Can you
Yeah.
Reddy and Girish and other Nata team, they really worked hard to make this event happen, which is timely and very useful for the community at large.
Yeah, thank you.
Absolutely. Thank you. Without them, this would have been.
I spent a lot of time in putting all the slides.
Yeah. They did a great job. They did an excellent job.
I appreciate that.
Thank you.
One more person to thank, Sridhar Chillar garu. He's a Mana TV and
TV. Agree.
Mana TV and TV5 CEO. Whenever we ask, he never says no, and he did the same thing again. He has been doing it for Nata for a long time. So, Sridhar Chillar garu, thank you once again. We are going to work together. So, Nata and your Mana TV and TV5. Thank you.
Thank you, Sridhar.
Appreciate it.
I also personally want to thank everybody and thank Nata and thank all the speakers and Dr. Astrazeneca Reddy for organizing this and bringing everybody together. This has been great.
Thank you, Praveen. I thought, I know we learned a lot, but still, I want the speakers as a conclusion, in the same order that they came. 1 minute parting comments. Nagi, then Dr. Talwar, and then Vishnu. Can you give me a one minute parting comments, Nagi?
This is, I think, my suggestion is take the vaccine and keep the mask on at least for some time.
Thank you.
Thank you.
Same as we developing newer medications to treat this condition and decreasing the end organ damage of ARDS, renal injury, etc. To decrease the mortality, to build the herd immunity, we have to take the vaccination and continue the social distancing and mask at this point.
Thank you. Vishnu.
Yeah. Hi. As I've watched this virus, it's a virus like any other virus. I've watched the Indian community, especially in the United States, in Chicago, be disproportionately affected because they like to get together despite the virus raging. And I've personally watched several of my friends, and I have a close friend of mine who's right now with the tracheostomy. He's another gastroenterologist, unfortunately. And people don't understand the seriousness and how devastating this virus could be. So be safe, socially distance, and get your vaccine and wear your mask is the message. And go out and become a trusted messenger out there and help others around you during this time of need. I mean, helping others is what makes life worth living. So go ahead and do that. Thank you. Have a good night.
Great comments. Thank you all.
Right. Thank you.
All three speakers, excellent speakers. Thank you for your time, and thank you for the audience for participation. So we can conclude this webinar then.
Thank you all. Nageswaradi,
Thank you.
Aloha.
Thank you all.
No,
Thank you,
everybody.
everyone.
Thank you all. Good night.
Good night.
Good night.
Dr. Reddy, Dr. Nageswar Reddy, and Rose will smell good with any other name as well. So please pardon me.
No problem. In fact, in our part of the country, there's a big struggle between Reddys and Raos.
Yeah, I knew that. That's why I said a joke.
Two common Telugu names. Dr. Talwar, have you ever been to Andhra Pradesh?
Of course, Charminar, you have to say it. It's a part of the in India that we are proud of. Of course.
Yes, yeah, that's good.
Just to let you know, my father was actually he was a freedom fighter, and he against the Nizam. He was arrested, and he was in Hyderabad jail for 6 months in 1946.
Oh
He has
my
passed
gosh.
away.
Wow.
Yeah.
But yeah, he was.
Oh my gosh. There you
It's
go.
interesting you compared Dr. Nageshwar Reddy to a rose. We don't get to smell too many roses as gastroenterologists.
Oh. No, you don't.
That's okay. You got other benefits anyway.
We have other benefits.
Oh, by the way, as you said, I don't know. I think some of you know those who practice here in US. Know the federal government has extended the public health emergency by 90 days more, starting from January. So now all the benefits that we're getting, like reimbursement for telehealth and other waivers or concessions that you have due to COVID-19, have been extended to April 2021. So by
Okay. Yeah.
so you see the public health emergency has been extended last week.
Okay. That's
Yeah.
great. Yeah.
All right.
Okay.
All right, thank you.
Okay.
Thanks, Mohan.
Okay. Thank you.
Thank you all.
Good.
Thank you, everyone.
Hi, it's me, Madhavi Lata. Please subscribe to GNN TV.